Mitral stenosis. What is it? This is where blood flow through the mitral valve from the left atria into the left ventricle becomes severely limited due to the narrowing of the valve. Etiology. The majority of cases are due to rheumatic fever, similar to aortic stenosis. The mitral valve leaflets become thickened and calcified and are unable to open during diastole. Long-standing mitral stenosis can eventually lead to pulmonary hypertension and eventually right-sided heart failure, also known as cor pulmonale. Mitral stenosis rarely occurs in isolation, and depending on the cause, can coexist with mitral regurgitation or aortic stenosis. Untreated mitral stenosis leads to dilatation of the atria, which may lead to atrial fibrillation and increased risk of thromboembolic events. Anticoagulation therapy should be considered at the time of diagnosis if the candidate is suitable. Symptoms. Mitral stenosis can go undiagnosed for years. The symptoms are non-specific and tend only to present when the patient has already developed atrial fibrillation, and this can be decades after the resolution of the initial rheumatic infection. These symptoms are exertional dyspnea, paroxysmal nocturnal dyspnea. This is where a patient feels the sudden shortness of breath in the night when they are lying down. Patients can also experience orthopnea, fatigue, hemoptysis, and Ortner syndrome. This is hoarseness in the voice due to compression of the left recurrent laryngeal nerve by the progressively enlarging atria. During the physical examination, a trained physician may hear a loud S1 and an early pathognomic diastolic opening snap, best heard in the apex. The S1 and S2 may also be palpable on physical examination in the apex and sternal borders, respectively. Diagnosis. The best diagnostic test for identifying mitral stenosis is echocardiogram, but should be supported with an ECG and a chest X-ray to rule out any other conditions. On an ECG, we may see evidence of atrial enlargement with a prolonged P wave greater than 0.12 milliseconds. On the chest X-ray, we may see straightening of the left cardiac border instead of its usual oblique position. An exercise test may also be considered if the patient is asymptomatic and is able to tolerate the test. This may assist in evaluating pulmonary pressure and disease progression. Cardiac catheterization may also be considered prior to intervention to assess any comorbid coronary artery diseases. Treatment. Treatment can be supportive or surgical. Supportive treatment is preferred for patients who are not displaying any symptoms, and they may simply require prophylaxis against rheumatic fever. Patients with mild symptoms may benefit from diuretics, beta blockers, or calcium channel blockers to help with rate control and load. Surgical treatment is only considered where patients have severe mitral stenosis and have not benefited from supportive treatment. A balloon commissurotomy may be percutaneous or surgical. A percutaneous procedure passes the balloon through the left atria into the valve and directly dilates the valve to allow blood to flow. The surgical procedure follows the same concept, but is performed under direct vision and a stenotomy. Where commissurotomy is not suitable, the patient may be considered for valve replacement. Patients given a valve replacement will be required to take lifelong warfarin prophylaxis to prevent risk of thromboembolic events. I hope you enjoyed this bite-sized revision video on mitral stenosis. Feel free to leave a comment, like and subscribe if you'd like to see more videos like these. Also, head over to my Quizlet link in the description for free revision flashcards. Happy revising!